Okay, it is my pleasure to introduce Dr. Blazquez. She is a specialist in assisted reproduction and focuses her research on the clinical outcomes of gamete donation cycles, and she works in the group Eugene in Barcelona. So, Dr. Blazquez, the floor is yours. She's going to talk about perinatal outcomes in third-party reproduction.
Yes. Well, I want to thank the organization to invite me to speak about perinatal outcomes in oocyte donation recipients. First of all, I want to introduce you to Maria and Julia. They are both age 35, and they are on their 20th week of pregnancy. The only difference between them is that Maria has been pregnant through an intrauterine insemination with her partner's sperm, and Julia, after an oocyte donation, also with her partner's sperm. So now that they have both passed the first term of pregnancy, do you think that they have the same risk for the same perinatal complications, and so do they need the same obstetric checkups? And during the presentation, we will be able to answer this question. I will divide the presentation into 4 parts. First, a brief introduction. Then we will see the perinatal outcomes in oocyte donation pregnancies. We will see preeclampsia in more detail, and finally, the take-home message. Oocyte donation embryo transfers have increased all over the world. From 2008 till 2010, they have increased nearly 36%, especially due to the increase in Europe. The reasons for this increase is because the indications for oocyte donation have expanded. Apart from the classical ovarian failure, that it could be spontaneous or iatrogenic, we have to add the repeated IVF failure, the genetic causes, or maybe the most common, that it's ovarian aging. It's common knowledge that oocyte donation pregnancies have an adverse risk for perinatal outcomes, but the question is why? Could it be the predisposing factors of these patients that need oocyte donation? Because usually they are of advanced age, they are usually also nulliparous, and they can have also concomitant pathologies. Maybe it's the multiple gestations. We all know that in oocyte donation we have an increased rate for twin pregnancies. It also could be the cause of the infertility. For example, in ovarian failure, we can find antibodies against the granulosa cells and the zona pellucida, and maybe these antibodies can cause damage to the trophoblastic cells invading the decidua. This leads to an abnormal presentation, and finally, to problems during pregnancy. It also could be the treatment that we give them. The cultures in the lab or the hormones that we give them also are plausible causes to cause an abnormal pregnancy. Or maybe it's the oocyte donation that gives this increase in these adverse outcomes. We will see that these questions are not easy to answer because not all these factors are easy to adjust for during the studies. Now we are going to see the prenatal outcomes in oocyte donation pregnancies. This slide is maybe a summary of what you can find in the literature. There are a group of outcomes that are clearly increased in oocyte donation. For example, gestational hypertension, preeclampsia, and C-section in the maternal site, and preterm birth and low birth weight in the neonatal site. Then we have another group of outcomes that are clearly not increased in oocyte donation, as are gestational diabetes mellitus, small for gestational age, and birth defects. And then we find another group of outcomes on whether we cannot reach a consensus on whether they are increased or not. The reason for not achieving a consensus is because different studies report different results, and it's very difficult to perform a meta-analysis because they are very heterogeneous. And the reason for this heterogeneity is because some of them have adjusted for single and multiple pregnancies, and some others not. We also have to check which is the control group with whom we compare the oocyte donation pregnancies. It could be IVF pregnancies or spontaneous conception. Also, some studies have adjusted for maternal age and some others haven't. And finally, we have to check if they have included only fresh embryo transfers or they mix fresh and frozen embryo transfer. And well, we all know that the outcomes of these two kinds of transfers are different. So we are going to see only the outcomes that are clearly increased in oocyte donation. We will start with gestational hypertension. This is a meta-analysis from PECs. They have compared oocyte donation with natural conception and oocyte donation with IVF pregnancies. And in both cases, the risk is increased for oocyte donation. The meta-analysis from Mazoudian compare oocyte donation with other kinds of assisted reproductive techniques. Here they include insemination, classical IVF, and ICSIs, and the risk is increased for oocyte donation, or the comparison between oocyte donation and natural conception also reveals an increase for oocyte donation. And a meta-analysis from Storgard, they present all the results dividing into singletons and multiple. Here it's the comparison between oocyte donation and IVF pregnancies. And in both cases, in singletons and in multiple, the risk is increased for oocyte donation. Preeclampsia, it's maybe the outcome that has been more reported, and it's more clearly increased in oocyte donation, but we will see preeclampsia in a while. The last maternal outcome is cesarean section. Despite there is more controversy about this outcome, what meta-analysis show is that there is an increase for oocyte donation comparing with both IVF or natural conception. The reason for this increase is not well known, but on one hand, oocyte donation patients are usually older, and we know that with age we have more dystocias, and the contractility of the myometrium during the labor is less effective, so we have more emergency cesareans. But on the other hand, there is a high level of concern due to the age of these patients, the difficulty to achieve this pregnancy, and the anxiety of these parents that also leads the obstetrical team to perform more elective cesareans. And now we move on to the neonatal outcomes. The preterm birth is increased in oocyte donation pregnancies. This is a meta-analysis from Adams. They have compared oocyte donation with other kinds of conception. Here they compare IVF mixed with natural conception, and the risk is increased for oocyte donation. Or the Danish meta-analysis that shows, again, an increase for oocyte donation comparing with IVF pregnancies or natural conception pregnancies. And the last outcome is the low birth weight, that it's defined weight the day of the delivery, less than 2,500 grams. It's also increased in oocyte donation. The meta-analysis from Adams, again comparing oocyte donation with other kinds of conception, or the meta-analysis from Storgard comparing oocyte donation with IVF and with spontaneous conception. Maybe the most important thing about all this list of outcomes is that when we adjust for multiple pregnancy and for preeclampsia, these neonatals improve. That means that part of this prematurity is due to the induced labors that obstetricians perform in order to finish the pregnancy, that we know that it's the only curative treatment for preeclampsia. So our goal should be to decrease the rate for multiple pregnancy and for preeclampsia. Preeclampsia is one of the research lines of our group, and we will see this outcome in more detail because, as you will see in a while, it's one of the major factors for these adverse neonatal outcomes and maternal outcomes. It's defined as gestational hypertension and proteinuria that appears at or after 20 weeks of pregnancy, and it affects between 2 and 8% of pregnancies. In developed countries, it's increasing. It can be classified into two subtypes. We have the early onset preeclampsia that appears before the 34th week of pregnancy, and it's due to an immune maladaptation of the mother to the fetus. This immune maladaptation takes place in the placenta, so it's an intrinsic placental dysfunction, and that's why it's also called placental preeclampsia. Then we have the late onset preeclampsia that appears at or after 34 weeks, and it's due to a hidden cardiovascular dysfunction of the mother that leads to a hypoperfusion of this placenta, so it's a secondary placental dysfunction, and that's why it's also called maternal preeclampsia. The early onset is associated with preterm delivery, so it's more severe. We find preterm newborns, and also it's associated with intrauterine growth restriction. The late onset preeclampsia is usually associated with term delivery, and that's why it's less severe. The pathogenesis of preeclampsia is unknown. The common point in all theories is that there is a uteroplacental hypoperfusion that leads to a chain of events, and finally the features of preeclampsia, as are the hypertension or the kidney symptoms. The question is, what is the trigger of all these chains of events? And then we have one theory that is the immunological theory, that it's based on the uterine natural killers of the mother. These natural killers have a different function of the systemical ones because they modulate proangiogenic and endothelial factors that make some changes in the spiral arteries and finally favors the perfusion of the fetus. The HLA-C of the trophoblastic cells have alleles from the mother and alleles from the father. There is known that some combinations of HLA-C with certain KIRs leads to a dysfunction of these uterine natural killers, and that leads to a dysfunction of this vascularization of the placenta, and finally pregnancy disorders, as it could be preeclampsia or intrauterine growth restriction. It's also postulated that when this HLA-C is less recognizable for the mother, for example, after an oocyte donation, because then both alleles are external to this mother, this also leads to a dysfunction of these uterine natural killers, a disturbance of this vascularization of the placenta, and that could lead to the preeclampsia. This immunological theory supports the early onset preeclampsia because in this kind of pregnancies we find small placentas with histological signs of hypoperfusion. Fetus are usually small with intrauterine growth restriction, and during pregnancy, Dopplers are pathological. But what happens with the late onset preeclampsia? Because in these other kinds of pregnancies, placentas can have normal sizes. They have less signs of hypoperfusion. Fetus can also have normal weight, and Dopplers during pregnancy could also be normal. And that's when the cardiovascular theory comes in. Some studies report that in patients that have had preeclamptic pregnancies, in the future they have more risk for cardiovascular events. But some other studies what say is that these risk factors are present before the pregnancy, are associated with preeclampsia, but can predict these future cardiovascular risk factors with more strength than the preeclampsia itself. So what this theory says is that there are some women with pregestational cardiovascular risk factors. We know that pregnancy is a state with an increase in hemodynamic and metabolic demands, and maybe for these women, these demands could be excessive. That will lead to a hypoperfusion of this uterus and this placenta, and finally to the preeclampsia. This is a list of risk factors for preeclampsia. I just want to make you aware that some of these risk factors are very present in patients that need oocyte donation. They are usually all. They are usually nulliparous with no previous children. They need oocyte donation to achieve a pregnancy, and so they have a higher risk for multiple pregnancy. With all this background, we wonder if are really pregnancies from oocyte donation at a higher risk for developing preeclampsia than IVF pregnancies. And so we perform a meta-analysis that was published in 2016, where we analyzed retrospective and prospective cohort studies that analyze the incidence of preeclampsia between oocyte donation pregnancies and IVF pregnancies. We only select the comparison between oocyte donation and IVF because then we avoid the bias of the reproductive treatment that we would have if we had also select natural conception pregnancies. We analyzed more than 26,000 cases, and we found an incidence of preeclampsia in oocyte donation pregnancies of 17%, and in IVF pregnancies, nearly 6%. Our results show that oocyte donation gives a threefold increase in the likelihood of developing preeclampsia if we compare with IVF pregnancies, even if we adjust for maternal age or for multiple pregnancy. The meta-analysis from Masudin that was also published in 2016 compared oocyte donation with other kinds of assisted reproduction, and again, the risk for preeclampsia is increased in oocyte donations, or with natural conception, where the increase is even higher in oocyte donation. And the meta-analysis from Storgar, also comparing oocyte donation with IVF, the risk is increased in singletons and in multiple for oocyte donation, or also comparing with natural conception, the risk is increased for oocyte donation. So we conclude, if it's not the assisted reproductive technology, if it's not the maternal age, and if it's not the multiple pregnancy, maybe it's that this embryo that it's from an oocyte donation, it's less recognizable for the immunological system of the mother, and that leads to a dysfunctional immune response that is responsible of the preeclampsia. And then we ask a second question, are maybe pregnancies from double donation of gametes at a higher risk of preeclampsia than pregnancies from only oocyte donation? Because maybe in reproduction, the more the gametes are donated, the more the risk to develop preeclampsia. And then we have performed a study where we have analyzed the incidence of preeclampsia between 81 double donation pregnancies and 352 only oocyte donation pregnancies. We haven't found any difference between groups in age, BMI, or obstetrical history. There's no cycle and pregnancy differences between groups either in the number of transfer embryos, the morphology of these embryos, the rate of multiple pregnancy, the type of labor, and the gestational age at birth. And there is no any differences in the gestational hypertension or the preeclampsia overall between groups, but when we divide between preterm preeclampsia and term preeclampsia, there is an increase in the risk of preterm preeclampsia in double donation comparing with only oocyte donation. Even if we adjust for age, primigravity, or multiple pregnancy. So if we remember, the origin of preterm preeclampsia, it's related to an immune maladaptation to the mother, to this fetus. And the origin of term preeclampsia is related to some cardiovascular predisposing factors of the mother. Then it's logical to conclude that in double donation pregnancies, where the embryo is completely allogenic to the mother, the risk, if we compare to oocyte donation, will increase only for preterm preeclampsia. And that's very, very important because the prognosis of preterm preeclampsia is very severe. Recently, a group from Paris has published a study, it's very similar to ours. They have compared 53 double donation pregnancies with 194 oocyte donation in women older than 43 years old. They haven't found any differences in the gestational hypertension, the preeclampsia, or other outcomes. They have only found an increase in gestational diabetes mellitus in double donation comparing to oocyte donation, although they haven't been able to explain why. And we think that the differences between their conclusions and ours is because they haven't divided between preterm preeclampsia and term preeclampsia. And nowadays, it's very important to present the results separating between these two subtypes of preeclampsia because the prognosis of them are very different. And to finish, the take-home message. We can conclude that oocyte donation is associated with placental pregnancy disorders, especially with preeclampsia. It's also associated with C-section and with some adverse perinatal outcomes, especially preterm birth and low birth weight. But these outcomes improve when we adjust for multiple pregnancy and for preeclampsia. So, which are the preventive measures that we have to take into account? Always single embryo transfer in oocyte donation. And our second goal should be to decrease the incidence of preeclampsia. The NICE guidelines say that in women with one of these high risk factors for preeclampsia or two of these moderate risk factors for preeclampsia, we should give aspirin during the first term of pregnancy to decrease the risk for developing preeclampsia. Nowadays, oocyte donation is not a risk factor, but maybe in the future it will be included as an independent risk factor for preeclampsia. Meanwhile, patients like Julia should be aware of their risk for some obstetrical and maternal adverse outcomes, and they should receive strict monitoring during pregnancy in order to start prophylactic measures as soon as possible to decrease the the risk of developing preeclampsia. Thank you very much.